From the nation's capital in Washington, D.C., Cole on Congress. The program discussing national issues that affect Oklahoma. Your host, U.S. Representative Tom Cole.
Thank you for joining me for another edition of Cole on Congress. Today's guest is Dr. Robert Moffit, who's the director of the Center for Health Policy Studies at the Heritage Foundation here in Washington, D.C. Dr. Moffit's a former senior official at the U.S. Department of Health and Human Services and the Office of Personnel Management during the Reagan administration. He's been a leading voice on health care policy for 25 years. Dr. Moffit, it's great to have you here. I got to ask you right up front, can I call you Bob?
Absolutely.
Okay,
no
very
problem.
good.
Gee whiz, thank you so much, Congressman.
Oh, thank you so much for joining us. You know,
sure.
We usually have other members of Congress, and I think the average viewer doesn't realize, frankly, how often we depend on people like you, from people like the Heritage Institute, to help us get informed about the issues that we have to vote on. So you perform probably more of an important public service than, frankly, most people in Congress do. So thanks.
Well, thank you. Thank you very much.
This year,
I'm not responsible for the problem.
No, but we're going to ask you about the solutions. This year, of all years, I mean, your expertise in healthcare policy is, probably the most important question in town. Now, I'll turn on that. So let me actually do a little bit of history first, because you played such an important role in 1993, the last time we had the great national debate on healthcare.
Yes, that's right.
How would you compare the proposals that are coming out of President Obama and the Democratic majority with what you saw from President Clinton and the Democratic majority in the early 90s?
One thing that struck me about this, Congressman, is that the presentation of the issue on the part of President Obama is very, very different than President Clinton. The substance, however, is remarkably similar. If you look at the key elements of the Clinton plan and the Obama plan, the big pillars of this giant, massive healthcare reform, most of the pillars are actually the same. For example, he would rely for financing on an employer mandate. So did President Clinton. They both relied on an individual mandate. In the Clinton mandate, the mandate was part of the individual mandate, was part of the employer mandate, but every American was expected to have coverage. President Clinton had a card that he would say that every American would get a card, which was a health security card. And he advertised it as saying healthcare that is always there. A very attractive idea. But then also, with regard to the substance of the program, the other big elements of it, besides the mandates, were the substance of the benefit packages. If you looked at the Clinton plan, the federal government was going to determine what kind of benefits every American got, what kind of benefits they would get, what kind of medical treatments and procedures they would get, what they would pay for them, how they would pay. The Obama proposal is basically the same. I mean, in that sense, the federal government is going to make a determination about what you get or what you don't get in your health care benefits package. And finally, with the Obama plan, much like the Clinton plan, there's a massive transfer of regulatory authority from the states to the federal government. So the federal government, in other words, is going to make all of the rules with regard to underwriting, with regard to how insurance is going to be marketed. All of these items that are normally within the jurisdiction of state departments of insurance are going to be subsumed under the Obama plan in the federal government. The one big difference between the Obama plan and the Clinton plan is Obama would create a new government-run program, basically a new health program to compete against the private health insurance system. That's different. Clinton never proposed anything quite like that. But that separates the Obama plan. But otherwise, the rest of it looks very similar in many respects.
I want to hold that public option because I want to come back and talk to you about the consequences. But one of the things that clearly is the great driver in this debate is a figure that we all hear every time we turn around. There's 47 million or more Americans without health insurance. Could you analyze for us a little bit about who those 47 million people are and how concerned we ought to be, and maybe some other approaches that might help address that
No,
issue.
it's a fair question. I mean, the 47 million figure is a Census Bureau figure, and it's basically a snapshot. That's what it is. So every year they do a snapshot of the people who are uninsured, but there's been a lot of work done on the uninsured. The fact of the matter is, Congressman, we have studied the uninsured to death. We can count the hairs on their head. We know where they live, But most of them, overwhelmingly, the vast majority of them are people who are relatively young, between the ages of 18 and 34. Overwhelmingly, they're working people. We're not talking about deadbeats here. We're talking about people who are, 80% of them basically are in working families. So they've got a full-time person who's actually bringing home a paycheck. They are heavily concentrated in small businesses. The uninsured are overwhelmingly concentrated in small businesses. They're disproportionately minority. The largest concentration in this group of uninsured people are Hispanics. There are a significant number of the uninsured who are, in fact, illegal immigrants. They are counted as uninsured, but in fact, they're not residents of the United States. The question, though, is how serious is the problem? Well, the problem is serious because the frequency of the numbers of uninsured seems to be going up. Why? Is because most of the people who are uninsured are people who do not get health insurance through the place of work. You find a large number of these people in small businesses. You find them as temporary workers. They're contract workers. They're heavily concentrated in the service industries, restaurants, for example. And they go from job to job, and the employer doesn't offer them health insurance. The problem, so we know this is a serious problem, but it's manageable. And that's an important point. This is a manageable problem. Most of the uninsured are not uninsured for an entire year. A lot of people don't know this. This is a very, very diverse and dynamic population. What the numbers show, what the research shows, is that people who are uninsured are people who had health insurance, but they lost it. And they lost it primarily because of a change in their job. That tells a lot about how we can fix this problem. In answer to the more specific question, with regard to the people who are chronically uninsured over a long period of time, the research on that says that actually among the total number of uninsured over, say, a 4-year period, the actual number who are chronically uninsured, people who are persistently out of coverage, is actually relatively small. It's about 12% of the total. So this is a tough
47 million? Or?
Well, no, actually, if you take it over a 4-year period, you'll get something like 80-some million people who are uninsured. Of that 80-some million, roughly 12% of them are people who are chronically uninsured.
Under 10 million people.
Well, that's right. So you're dealing, in other words, with a problem of frequency of uninsurance, people falling in and out of coverage, a churning in the insurance market. You're not dealing with a large number of people who are chronically uninsured. But the data tells us one big thing, and it tells members of Congress something very big, which is this: if you can establish portability in the health insurance markets, in other words, if people can carry their health insurance from job to job without either a tax or a regulatory penalty, even if we didn't spend a lot of money on this, in other words, even if we didn't spend a dime, if we had portability in insurance like we have it in life insurance and auto insurance and homeowners insurance, if we did that, the numbers of uninsured would drop dramatically. Because most of the problem is basically people having insurance and losing it because of a change of jobs.
Let's talk about that big difference that you pointed to, which was the presence of the government option in the president's plan. Now, the argument for it is this is to, quote, make the insurance companies compete honestly, that it'll compete on the same level. It's simply there as almost as a last resort, not as a first resort. What kind of concerns do you have that plan will become default and you'll begin seeing literally companies ending insurance and saying, look, you can go over here to the government plan?
The idea that it's just an option, to expand choice and competition for individuals, frankly, is nonsense. The public plan will undermine private insurance, and it is not going to be on a level playing field. There's no evidence in the research literature, and there's nothing in the bills of the House or Senate bill that guarantee that this public plan as going to be simply just like any other insurance plan. It's going to be subsidized by the taxpayers. But more importantly, if you really wanted a purely competitive market with a level playing field, well, then all the rules that apply to private health insurance would apply to the public plan. In other words, the public plan would be under the same rules for accounting standards. In other words, they wouldn't be able to run unfunded liabilities like the Medicare program runs right now, where the current and future taxpayers are saddled with literally trillions of dollars of unfunded debt in the Medicare program. Well, no. I mean, the public plan is going to be subsidized by the taxpayers. The taxpayers are going to assume all of the risk for that plan. That means the liabilities and the losses are ultimately going to be with the taxpayers. The plan is not going to be subject to the state or federal taxes. The plan is not going to be subject to the same kind of tort laws that govern private health insurance, the same kind of contract laws that govern private health insurance. So I don't see how you're going to have a level playing field. In fact, what the research shows is that the public plan will have an artificially low payment rate to doctors and hospitals based on the Medicare program, which is going to be able to enable the plan to offer a premium which is below the market price. But the plan comes with another key element, and that's the employer mandate. In the House bill, the employer mandate is anywhere between 2 and 8%. Most employers would pay about 8%. If an employer has to pay a tax or offer coverage that is required by the federal government, a lot of employers are simply going to say, look, I don't want the hassle of negotiating with private health insurance anymore. What I'm going to do is I'm just going to dump my employees out of their private coverage into a public plan. It's not going to make, regardless of what the president says, and I'm not suggesting he's being dishonest, but when the president says that you can keep the health insurance you like and the insurance that you have, that's not true. It simply cannot be true. All the incentives are for employers to dump employees out of their private coverage into the public plan. And the research shows that millions of Americans, literally millions of Americans, will lose the private coverage they have today and go into the public plan. The most recent analysis is that done by the Lewin Group, which is the top econometrics firm in this country. They have just done another analysis following their testimony before the House Energy and Commerce Committee and the House Ways and Means Committee, and they have estimated that 103 million Americans are going to end up in the public plan, regardless of whether they want to be in the public plan or not.
Well, you know, if you're a business person and somebody says, look, you can get rid of all these hassles for 8%, and a lot of businesses are paying 11 and 12 now.
Right.
It's a no-brainer.
It's a no-brainer.
I mean, plus you always have the ability to bargain with the politician in a way that you don't with an insurance company. But that leads you to another consequence, aside from the movement, right, of people out of private plans into this public option. Right now, as I understand it, a great deal of the health provider system is financed by private plans. That is, we fund from Medicare.
Oh, yeah.
Maybe 83, 85% across the board in terms of real cost. Mm-hmm. So everybody that's not on Medicare really pays more in terms of their private insurance, whether it's a business or whether you're writing it individually. But if that pool shrinks, how in the world are you going to finance Medicare? And how in the world are you going to keep private rates from skyrocketing just beyond belief?
Well, that's the likely effect of this, is that right now, you're quite right. Medicare shifts costs to everybody watching this program. It pays for Medicare beyond their payroll taxes for Medicare. They pay for Medicare. If you're a senior, you pay for Medicare with your premiums. We all pay for Medicare through general revenues. We pay for Medicare through the premium taxes. But another source of Medicare, basically, is the cost shifting that goes on between Medicare and the private sector. When doctors are only being paid 81 cents on a dollar, which is the way it is nationally, for Medicare, what they do is they say, okay, I can't get the full reimbursement for the cost of my services from Medicare, so when the person who owns private insurance comes through the office, they shift those costs onto private payers, and so private health insurance picks up those costs. Nationwide, the Milliman Group, another top econometrics firm, estimated that the typical American family pays about $1,800 a year additionally in premium, just to cover the cost from cost shifting from Medicaid and Medicare to private health insurance. So we're paying it's a hidden tax. We're paying a big tax right now on Medicare and Medicaid because of the way Medicare and Medicaid pays doctors and hospitals. But there's another problem here. With the public plan, all of that cost shifting will be aggravated. The Lewin Group estimated that on looking at the cost shift from an expansion of the public plan, that you can add another $460 on average to the typical family's health care benefits package. Now, if the private health insurance companies and private payers, if the people who have private health insurance are already carrying the burden of Medicare and they have to carry the burden of the new public plan, once again, you're not talking about a level playing field. This is a tremendous imbalance, basically organized. It's rigged competition against the private sector in this kind of an arrangement. The result of it, of course, is that you will have a massive shrinkage of private health insurance coverage. You'll have less choice. You'll have less competition. And conceivably, with the decline in the number of private health care plans, the public plan becomes the equivalent of kind of the Roach Motel. You can go in, but you're not really going to get out. That's it. You're going to get what they give you, and that's the end of it. And of course, the benefits are going to be determined by the Secretary of Health and Human Services and some kind of benefits advisory committee that's going to make all kinds of determinations about what you will get on a year-to-year basis. That's not an inviting proposition. No. Okay? It's not an inviting proposition. It's not the hope and change that we thought we were going to get.
Probably not. Probably not. We've had other examples of efforts at the state level. I know you were heavily involved in the effort in Massachusetts to provide coverage there. Tell us how that works and what's the verdict on it at this particular point in time.
It's very much, Massachusetts was a compromise between a conservative Republican governor and a very liberal legislature, liberal Democratic legislature. So from the beginning, it was a mixed bag. The good things in the Massachusetts plan, in fact, are very good. I mean, first of all, you had a dramatic reduction in the number of people who are uninsured. In Massachusetts right now, 97% of residents are insured. I mean, that's very significant. You've also had a major change in public financing in Massachusetts, which was Governor Romney's signature achievement. In Massachusetts, they were spending like $1.3 billion a year on uncompensated care in hospitals. Massachusetts hospitals are different than hospitals in the rest of the country. It's the most uncompetitive hospital market in the country. So you had these very high-priced hospitals. You had people going into these hospitals and getting emergency care. And of course, the taxpayers would pick up the bill because if people didn't have the capacity to pay, they would simply pass on the cost to the rest of the citizens in Massachusetts. What Romney did was to take this $1.3 billion worth of uncompensated care funding from both the federal government and the states and turn it into a pool of vouchers or for financing. So instead of people getting health insurance through the emergency room or getting health care through the emergency room, they'd have health insurance when they went into the emergency room. That's a good thing. It's the use of government subsidies to basically expand private coverage. We can do that in many other states. We should do it in many other states. What they did not do well is they did not control cost well because they insisted on continuing to fund a lot of very powerful special interests in Massachusetts. Even though hospital uncompensated care costs were going down, by the way, they went down about 45%, 40%. They still continued to fund these hospitals. So the taxpayer still got stuck, with the bill. So they have not solved the problem of cost control. The other thing that they've done is they've imposed an individual mandate, but in fact, they backed away from it. They basically said that about 70,000 people are not going to be covered by the individual mandate because they said there was a hardship case. So we learned a big thing about the individual mandate in the most liberal state in the country, and that is if you're asking for an individual mandate to deliver universal coverage, it's not going to happen. If they can't have universal coverage in Massachusetts, they're not going to have it anywhere. And so that's been a problem for them as well. But it's been a mixed bag. There have been some very good things. There's no question about that. But they have not solved the problem of health care costs.
Let's talk about some of the other tools that are out there. While the president likes to say everything's on the table, a lot of things clearly aren't on the table.
No,
at least
that's
haven't been
pretty
on the table
Right.
so far in the course of this debate. Talk about some of the other things that might, and if you can, quantify as well as you can, make a difference. Things like tort reform.
Oh, absolutely.
Things like tax credit. Things like allowing everybody to buy their insurance with pre-tax dollars. I used to buy my own,
Right.
and have had to do that several times in my career, and it always bothered me to when I worked for somebody, they were using pre-tax dollars, and so was I. And frankly, when I was on my own, it was after the government had taken everything they could out of it before I could buy my insurance.
Absolutely. Well, Congressman, you probably know this probably better than most, but better than most members of Congress. But the truth is that the biggest problem for Americans who do not get health insurance at the place of work is they have to buy it with after-tax dollars. If you lose your job or you change your job and you decide, well, it's time to get health insurance, I have to buy health insurance outside of the place of work, I can do that. It's a free country. But the problem is, because you don't get any tax break for this, you could end up paying 30 or 40 or 50% more in premium dollars for the same package of benefits that you would have gotten if you got at the place of work. Now, this contributes directly to uninsurance. It is also profoundly unfair. What we say, in effect, is that if you do not get health insurance through the place of work and you try to buy it on your own, we're going to impose on you a tax penalty. I cannot think of anything worse from the standpoint of public policy than deliberately undercutting the access of millions of Americans to affordable health insurance that way. The second thing is that health insurance companies, just like auto insurance, life insurance, homeowners insurance, and every other firm in the free market economy, ought to be able to compete directly for consumers' dollars. They don't. They don't. And many of them, frankly, don't want to. But Congressman Shadegg of Arizona has said, fine, if you have a health care plan in New York or Washington, D.C., or if you have a plan in California that you think is not appropriate for you, and you want to buy one in Oklahoma, or you want to buy one in Iowa, you shouldn't be subjected to some kind of a legislative or regulatory restriction from doing that. We ought to have an open market where people can buy the health insurance that they want and keep the health insurance they trust and be able to take it with them from job to job without some kind of god-awful tax or regulatory penalty. So if we fix the tax code and we allow for competition in the market, we will in fact do two things. We will expand coverage dramatically. We know that. And at the same time, we'll start to reduce costs because we'll allow the market to do what the market does best, which is to ruthlessly control cost through the interaction of supply and demand, which is really what we need in this sector of the economy.
What's your view of one of the more popular Republican solutions? We passed it 4 times in the House when we were in the majority, never could get it through the Senate, was our associated health plans, basically allowing small businesses to pool and get a large enough risk pool across state boundaries to go ahead and buy a basic coverage package on the same kind of terms that larger companies can get.
There's nothing wrong with that idea, except I would just simply expand it. I would say don't confine association plans to just businesses. Allow all kinds of associations to offer health insurance across state lines. Why not, for example, trade associations, professional organizations? Why not enable religious institutions or faith-based institutions to sponsor health insurance if they wish to do so? Think about this for a moment. We have literally thousands of delivery institutions, hospitals and clinics run by churches in the United States. The Catholic Church has one. The Southern Baptists have these magnificent hospitals throughout the South, Presbyterian hospitals and so on. We have this kind of Berlin Wall between the financing of healthcare and the delivery of healthcare. But if we were allowing the creation of association-based healthcare plans across the country, you could have precisely the kind of rational integration of financing in healthcare where the Catholic Health Association and the Catholic health hospitals, could be united in presenting a package. The same thing is true with the Baptists and the Presbyterians, the Lutheran hospitals, the Jewish hospitals in New York and New England. All of this could be normal. It's not normal now because the stupid laws that we have prevent these things from happening. But if we were allowed this competition to take place and we would expand personal freedom of choice, we would solve about 80% of the problems we're facing. It doesn't solve it all. It doesn't solve it all. But if we were to solve the financing and solve the insurance and the tax laws, we would really be way ahead of the situation, way ahead of where we are today.
Well, of course, the other favorite Republican solution is tort reform, which we also passed several times and could never get through the Senate.
No.
But give me some idea what kind of difference that might make in terms of costs.
You know, that's an excellent question because there's never been a really good answer to it. The problem of tort reform is not just simply the problem of doctors paying very high premiums in certain specialties like obstetrics and gynecology and neurosurgery. We know that those premiums are high. It's also the fact that many physicians, when they look at the patient, they have to make a very, very serious internal calculation. If I do what I think is right for this patient, and I give this patient what I consider to be, based on the best professional training that I've had and my best judgment and experience, what is necessary or appropriate, how do I know that some other person, some other medical professional is not going to second guess me? They don't know that. And so what they do is they order extra tests, they order extra studies, they order extra procedures. They do things that they would not otherwise do. They call it defensive medicine. It is very, very hard to put a number on that because it's very, very hard to measure that behavior. But if anybody watching this program were to go to any medical meeting or any medical society and ask the question whether in fact they feel compelled to practice defensive medicine, the doctors will be honest with you and they will tell you that they do, to avoid the reputation ruining litigation that comes with medical malpractice.
We're down to just about a minute left, but let me ask you one last question. We've been having quite a discussion in Washington on the whole issue. What's your prognostication as to what's going to happen, and what's the quality of the debate been like?
I think the quality of the debate has not been good because the problem has been that the administration and its allies want to move this thing very quickly. And we're talking about a bill in the House that is 1,018 pages. We have sporadic reports from the Congressional Budget Office and also outside econometric analysis by Lewin and others on what the cost and the impact will be. But it hasn't really been thoroughly debated. I was struck by the story in the Washington Post recently that said that they had a 5-hour seminar for members of the House of Representatives, on this 1,000-page bill sponsored by the Democrats in the House. Well, why do you need a 5-hour seminar? Well, it's because people don't understand what it is. What I hope we do not have is a repeat of what we had with the stimulus bill and the cap and trade bill, where members of Congress are passing bills the size of a telephone book that they have not had a chance to read. They have not had a chance to absorb the impact of what it is they are doing. And that in this case will affect 300 million Americans.
Well, unfortunately, we have to wind it up right there. But I'll assure you I'll read the bill. And as it's written now, I'll be voting no. So thanks for being here. I appreciate you taking the time to come.
God love you. Thank you.